Hello, everyone, and welcome to today's Third Thursday webinar. I'm Dave Iverson, the contributing editor at the Michael J. Fox Foundation and the moderator for today's webinar on other Parkinsonisms, sometimes also refers to as atypical Parkinsonisms. A reminder that you can log in every third Thursday of the month at 12 noon Eastern Time, 11 Central, 10 Mountain, and 9 Pacific to hear a discussion about a topic that's important to everyone in the Parkinson's community. So we hope you'll continue to mark your calendar and join us on the third Thursday of every month, where you can join us live, but you can also watch our webinars on demand whenever you so choose. As always, today and on every third Thursday, you'll be able to submit your questions throughout the hour, which we will take up in the second part of our conversation today. You'll see a little Q&A box in the middle of your screen, so you just type your questions there, and we'll do our best to get to as many of your questions as you can. You also see on your screen right now a few little tips that we've put on the screen. We know sometimes there are some technical challenges with these webinars. We do our best to make these as accessible as possible, but we do have a few tips there. So as we're getting ready to get going, we want you to note those, and hopefully those will help in your processing of these webinars too. One other little note before we get started, the slides from today's webinar are also available for download. So there's a box called the resource list on your screen, so you can click on that link there, and a document will open in a new browser window, and you'll be able to click on that link at that time, and you'll be able to download that and take it from there. Okay, let's get going with our topic today. Other Parkinsonisms. So we're going to talk about what these atypical Parkinsonisms are. We're going to talk about what these various diseases look like. We'll talk some about what can be done to treat them. And then we're going to talk about the state of research into them and how research into each of these diseases may help people who not only are contending with those diseases, but also may help in the treatment of other diseases, including Parkinson's disease itself. And here's who's going to be joining us for our conversation today. Hadley Ferguson is joining us. Hadley is an artist living in Missoula, Montana. She was initially diagnosed with Parkinson's disease in 2011, but a couple of years later that diagnosis was changed instead to one of these atypical Parkinsonisms, something called multiple system atrophy. So Hadley, welcome. Thanks so much for being part of our webinar today.
Thank you very much. Thank you for having me.
We're so pleased that you could be part of our webinar today. Joining us as well is Dr. Lawrence Golby. Dr. Golby is Professor of Neurology and Director of the Division of Movement Disorders at the Robert Wood Johnson Medical Center at Rutgers University. Dr. Golby, thanks very much for being part of the webinar as well.
Thank you, Dave, for inviting me.
And Dr. Alex Pinteliat joins us too. He's Assistant Professor of Neurology and the Director of the Atypical Parkinsonism Center at Johns Hopkins University School of Medicine. Dr. Pinteliat, thanks as well for being part of our webinar today.
Thanks, David. My pleasure.
So let's get started and focus on this question of what are these atypical Parkinsonisms. And today we're going to focus on 4 of them. And we start with this definition, a condition that shares some of the motor symptoms of Parkinson's, that is tremor, rigidity, slowness, walking or balance problems. And we're going to focus on these 4. And you see them on the screen and something about their prevalence within at least the United States. Lewy body dementia being the one that is the most prevalent, also sometimes called dementia with Lewy bodies or diffuse Lewy body disease, progressive supranuclear palsy, multiple system atrophy, and corticobasal syndrome. And we're going to talk about each of these in some detail, so we won't spell out the nature of each of these at this point. But I do want to get us started by just asking a question about the prevalence of these, because we see these numbers, Dr. Golby, on the screen. They're quite small compared to the number of people who we think have Parkinson's. And I say we think because we're not in, that's not a very precise number either, but we usually say somewhere around around 1 million people in the United States have Parkinson's. Far fewer numbers here, but even this is not entirely clear, right? Because these diseases are so often misdiagnosed. So tell us something about what these numbers actually do mean, because they're based on what we think are the number of people who have them, as opposed to the people who have actually been diagnosed, correct?
That's right. The figure for Lewy body dementia is calculated indirectly because in clinics that see people with dementia, the Lewy body dementia is about 10% of the prevalence of Alzheimer's disease, and Alzheimer's affects about 800,000 in the U.S. And the PSP, I put the figure of 20,000 there because that is the number that you can arrive at if you comb through records of a well-ascertained population like they have at the Mayo Clinic or like they have in the British healthcare system. But actually, the number in the U.S. who actually carry a diagnosis by a doctor of PSP is only about 5,000, and the others are proportionately low.
Now, when you said a moment ago that 800,000 people have Alzheimer's, I think of the number of people in the United States with Alzheimer's as being far more than that. So this can get a little confusing. Can you help us understand those numbers a bit better, please?
Oh, I'm sorry. I said 800,000. I meant 800 per 100,000. That was a misstatement. 800 per 100,000. That compares to about 150 per 100,000 for Parkinson's disease. So if you multiply the 800,
okay.
Yeah.
I see. So there are about 6 times more people who have Alzheimer's than Parkinson's.
That sounds right. Yes.
Okay, great. So, but in essence, these are diseases that are fairly small in number, and yet are often misdiagnosed. And so there are more people out there who have them than who have actually been misdiagnosed. And that brings us to our story that Hadley is here in part to tell us today. So Hadley, start us out by describing what you first experienced as a young woman. This happened when you were still in your 30s. Tell us what you first experienced and what the doctor first thought was going on with you.
Sure. It was when I first had symptoms, I just noticed I'm a very active person. I stay really busy with a lot of projects and balance a lot of things. And I was getting fatigued throughout the day really quickly, and just exhaustion, which was very uncharacteristic for me. And my movements were slow, and my muscles were really rigid. And I was also having a lot of difficulty with sleep. So these things brought me into the neurologist originally. And it took a little while to sort out. In 2011, they tried me on a trial of levodopa, which I initially responded really well to. So they determined that I had young onset Parkinson's disease. And they didn't want me to stay on levodopa right away as I was young. And so I switched immediately to Mirapex, the dopamine agonist, and that worked marginally well for about the first year. I also didn't respond. I had a kind of a strange reaction to Mirapex, so I went off of that, and it was determined that levodopa would be a better option for me to go back on. When I went back on the levodopa a year later, it did not have the same effect that it had had when I had my trial, and so that was somewhat alarming for me, because it was sort of a magic pill when I'd first taken it. And so I asked for more, and I was increasingly adding more. A month or two later, I was having the dose more often throughout the day, and it just didn't seem to really be working for me. And on top of that, my symptoms were progressing. I had already had early balance problems, but it was becoming worse, and I was falling more frequently. Some autonomic problems were becoming more difficult, and my rigidity was pretty much throughout the whole body. And so they reevaluated my diagnosis, and in 2013 determined that I most likely had MSAP. And another piece of the picture that always seemed to be a thing on its own, which now made more sense, was that prior to all my Parkinsonism, I had had a lot of blood pressure issues and fainting spells, which had sent me to the ER, and so that was still a problem. And so now it seemed like that was part of this bigger picture.
And Hadley, it took a couple of years before that
Yes.
clarity came between 2011
Yes.
and 2013. Okay.
It did, yeah.
So let's then look then at sort of what begins to distinguish these, as they're sometimes called, as we see on the screen now, Parkinson's plus conditions. And we see some of the things that Hadley just mentioned. And so Dr. Pantelliat, listening to Hadley's story, that initially there was this Parkinson's diagnosis, didn't respond well to levodopa. She mentioned some other things that I'd like you to comment on. The quickness of the progression, the fact that the rigidity, which was on one side, which is typical in Parkinson's, but that it spread. Also these other more what we think of as autonomic features, those automatic functions in the body, things like blood pressure, which happen in Parkinson's too, but sounds like they were more acute in Hadley's case. Do those sound to you very, very typical of these features of these atypical Parkinsonisms, Dr. Pantelliat?
Well, David, yes, they certainly sound quite typical for multiple system atrophy, which, as the name suggests, affects multiple parts of the nervous system in a more widespread fashion than Parkinson's disease and earlier on. So the partial response to, even a good response, as we heard from Hadley, to levodopa is also quite typical and can actually last for a number of years. However, it tends to wane and is often not as robust as we expect from Parkinson's disease. So the progression, as we heard, is quite a bit quicker than is typical for Parkinson's disease as well. In some of the atypical Parkinsonian disorders we'll be talking about, particularly dementia with Lewy bodies and PSP, there's more cognitive difficulty earlier on. We'll talk about the specific types of that. That is really less true for multiple system atrophy. The walking and balance issues tend to come on much earlier in the atypical Parkinsonian disorders such as MSA. Often if a patient presents in a wheelchair or is requiring a rolling walker, for instance, within several years of the onset of any of the symptoms, that is a red flag, one of the signs that this may not be Parkinson's disease, but rather one of these atypical Parkinsonian disorders.
Dr. Goldby, do we have a sense of why? I mean, the bad news about Parkinson's, of course, is that we don't have a way of altering the progression of the disease. The good news about Parkinson's is that we do have a fairly effective way of treating at least the symptoms in carbidopa, levodopa. But as we've already heard from Hadley, that symptomatic treatment that's useful in Parkinson's, carbidopa, levodopa, doesn't seem to work so well in MSA, and that, as I understand it, that's also true in these other atypical Parkinsonisms that we're going to be talking about. Do we know why that's true? Why what seems to work, at least as far as helping with symptoms in Parkinson's, doesn't work so well in these other conditions?
It's probably because the brain cells that are supposed to receive the signals in the form of dopamine are breaking down in the atypicals, but they're not breaking down in Parkinson's. In Parkinson's, what's going on is that the cells that are producing the signals of dopamine are breaking down, which is also the case in the atypicals. So in the atypicals, you don't have the receptors, and so no matter how much of the chemical of the drug you supply in the form of medication, there are no receptors to receive the signals.
There's breakdown, but there's no receiver. There's no way to do any of the resupply.
Not by resupplying a neurotransmitter like dopamine. There may be other ways of rejiggering the circuitry. There may be a couple of things that we can do to help the symptoms of those diseases a little bit, but nothing that's anywhere near the effectiveness that resupplying dopamine has for Parkinson's, or directly stimulating the dopamine receptors in Parkinson's.
And would that also explain the rapidity of the progression, or is that a different problem that causes in these atypicals for the disease to progress so much more quickly than standard order Parkinson's?
No, I don't think it explains the speed of the progression. In fact, before levodopa came along in the 1960s, the speed of progression of Parkinson's was very similar to what it is for the atypicals now. So really all the diseases progress at approximately the same rate.
So the reason why Parkinson's progresses more slowly really has to do with the effectiveness of the symptomatic treatment that we have?
That's right.
Okay, all right. That's I think a really useful reminder, I think, about how fortunate, and it's odd to say that, but how fortunate in some ways it is to have a Parkinson's diagnosis as opposed to these others. And we'll talk then more about some of these other distinguishing aspects of these conditions, as Dr. Pantelliat already suggested, more cognitive issues, particularly in some of these other conditions, Lewy body dementia and progressive supranuclear palsy, and the walking and balance issues as well. Let's go to our next slide, though, and begin to talk about each of these in more specificity, and we'll bring Hadley's commentary back in just a little bit to talk more about multiple system atrophy. So we have on the screen now, Drs. Pantelliat and Golby, corticobasal syndrome and progressive supranuclear palsy. And we have at the top that they share something in common. What is it that they share? Why do we have these groups together? What is it about the two of these that makes them similar? Dr. Golby?
Well, they're all called atypical Parkinsonism or Parkinson's plus because they have Parkinsonism. And Parkinsonism means a combination of stiffness of the muscles and slowness or paucity or impaired amplitude of voluntary movement and loss of balance and sometimes tremor. So that whole picture, that syndrome, is called Parkinsonism, and that's what these all have in common. In addition, each of the diseases, including Parkinson's, has other things besides those.
And these two in particular, though, CBS and progressive supranuclear palsy, also share the same basic protein problem, right? They share the protein that clumps together, the protein tau. And does that mean then that they also share similar progression, similar symptomatic problems?
No, the nature of the protein, the specific protein that's clumping, doesn't dictate the type of symptoms because there are many degenerative diseases, neurodegenerative diseases that affect the same areas of the brain but have different proteins clumping, and yet they have the same symptoms, and that's dictated by the anatomy, the geographical area that's involved. I want to point out that in corticobasal syndrome, there's several possible proteins that can clump up. At some level, you could call these different diseases. And when it's the protein tau, we call it corticobasal degeneration. In PSP, it's always tau.
And Dr. Pantelliat, I know you see in particular a lot of people with PSP. describe for us, if you will, some of what you see as far as the common, if there is such a thing, as a common PSP experience.
Well, I would want to emphasize that we have recently learned a lot more about how heterogeneous, how variable different presentations of PSP can be. But in the case of classic PSP, what we refer to as Richardson's syndrome, there is an early tendency to lose balance, particularly leading to backward falls, which of course are very dangerous, hitting the back of your head, for instance, as well as a restriction of vertical up-down eye movements. And if that occurs very early on in the course of the onset of symptoms, and we're able to observe that clinically in the office when examining the patient, that would present really the classic PSP Richardson's syndrome. In addition to that, people may have difficulty with frontal executive function. So as the slide mentions, difficulty planning, multitasking, organizing thoughts, as well as apathy, progressive increasing indifference over time to what was previously interesting, hobbies that people were involved in, for instance. There can also be mood and behavioral changes early on, and PSP can also present with profound speech difficulties, difficulty coming up with the words one wants to use. So we call that aphasia, which progresses over time. And all of these, I should stress, are in addition to the Parkinsonism spectrum of symptoms that Dr. Golby was just mentioning. I would just quickly add the point about tau protein. So as Dr. Golby was mentioning, PSP is thought of as a pure tauopathy, and we now know there are multiple types of tau protein, and the tau protein that builds up in PSP is referred to as 4-repeat tau. Without going into too much detail, corticobasal syndrome, at least about 50% of the time, as the slide shows, is caused by 4-repeat tau building up as well. So in such cases, there could be a really significant clinical overlap in how corticobasal syndrome and PSP present.
So a question that's come in about someone who's been diagnosed with cortical basal, and the question has to do more with aspects of behavior than it is actual physical symptoms. But someone who has from a spouse, someone who has that their spouse exhibits a kind of loss of empathy, is more doesn't engage with other people, shows a lot of kind of anger, and very self-absorbed. Is that kind of apathy is something that can also be characteristic, of course, in Parkinson's as well. Would you say, Dr. Panteliad, are those symptoms? Are those symptomatic? Are those indicative of the disease, or are those perhaps things that are indicative of how this individual might be dealing with the disease? I know that's a hard thing to discern, but are those some of those non-motor things that are very, very much a part of Parkinson's? Are those also part of these diseases as well?
Most certainly, and in fact, as I think you're suggesting, it's these non-motor manifestations that could be the most distressing and most limiting, impairing to the quality of life of patients and their family members. That is also often true in Parkinson's disease. It's interesting that the question mentioned loss of empathy in particular, in addition to the apathy that we were talking about, loss of interest and indifference. Without wanting to complicate things much further, there is an umbrella term that covers a number of the Parkinsonian syndromes that we're talking about today, and that is frontotemporal lobar degeneration. One of the variants of FTD, there are several types, corticobasal syndrome and PSP fall under this umbrella term of FTD. One of the variants is called behavioral variant, BVFTD, and the loss of empathy in addition to the apathy, these prominent anger, behavioral symptoms are really quite classic and typical for behavioral variant FTD. So that just underscores the fact that these clinical descriptions that we're talking about today often fall on a spectrum that overlaps with other clinical descriptions. In this case, as the question was asking, it sounds like BVFTD should be an important consideration in addition to what was mentioned as corticobasal syndrome.
And does that then also mean, Dr. Golby, that these conditions, and we'll talk more about treatment in a moment, but just as with standard Parkinson's, that use of antidepressants or other kinds of therapies, can they be useful in dealing with some of these non-motor aspects of these conditions?
Well, the antidepressants have never really been convincingly demonstrated to work in these disorders, but they're still worth trying. Sometimes they do. There'll be a few patients who do respond to them, and they're relatively safe, relatively inexpensive, and so it's worth a trial. Especially the disinhibition that can occur, especially in PSP, may respond to antidepressants.
Disinhibition, acting out, that kind of thing, which is something that can occur in some of these. Another one of the symptoms that we don't have listed, but I know can come up in this as well. Let's have Hadley rejoin our conversation and go on to describe two more of these conditions and go back to multiple system atrophy, and then also talk about Lewy body dementia, because we have a number of people who want to ask questions about that particular atypical Parkinsonism. And Hadley, we see on the list here of multiple system atrophy, you described already some of what you experienced when you were first diagnosed, but pick up a little bit more, if you would, on some of how this has gone on to progress with you and how you are dealing with some of these symptoms. First, if you would, talk some about the motor difficulties, the walking issues, and then if you would, I also want you to describe some of the autonomic, and then we'll talk about some of the cognitive questions that you're contending with too.
Sure. So walking through this list, the balance it was an early issue for me, and that creates a situation where I can fall pretty easily, and I started using a walking stick pretty early on. Walking is difficult with long distances. I try to get out every day for something, even if it's a couple blocks, to try to get myself moving, and I feel lucky that I'm still able to do that. But for a tool, I have a wheelchair that is it's a fold-up wheelchair that has a motor that attaches to the back of it, a power assist that I can put on the back of my wheelchair and walk my daughter the 9 blocks to school or take her to the park. It's really given me a lot of room to continue my life as I'd like to continue it. And in the wheelchair, it's similar with walking. My arms just get fatigued rolling the wheelchair, so the power assist is really helpful with making that more useful. And with the speech, I don't have slurred speech. I did have some issues with my voice volume level, and I went through the LSVT Loud program. It's a program that helps you with making your muscles stronger so that your voice projects better. I work on those exercises daily, and I think that's really important to keep every muscle moving and to keep it working. With the mobility, the earlier mobility of walking and balance, I also go to regular PT, and the pool has been really wonderful because I may not be as balanced on land, but in the pool I can do a lot more, and it helps me work more of my muscles. I also the medication that I take is helpful for all those things. So I make sure that I keep up with all of that and daily check-ins for that. As far as the autonomic dysfunction goes, blood pressure regulation was a really early thing for me, and I had a lot of ER visits that I'd mentioned. I still now, it's a joke in my family. It was at the time. Now it's not quite as funny knowing what it's from, but I would tell people I'm going out now, and I can tell the pattern, and I stand up, I get dizzy, and then I'm down. And so that was an early issue, and I now it's just a matter of knowing when to be safe about it. And then I had some urodynamic testing for my bladder issues. I had early bladder issues and constipation, and so everything on the list I've had experience with. I think it's important to keep up with all of those things. I take a lot of medication for both the bladder and the constipation, because if those two get out of balance, I notice that everything else is worse. So I do my best to keep everything moving. As far as the cognitive issue, I know that's not as normal in MSA, but I have experienced that in the last couple of years. It's been more pronounced, and I'm an artist, and I do a lot of public park projects, and I work with committees and research, and it's been very difficult for me to keep all of that managed and sorted. It's also been difficult in situations of going to a store and navigating the aisles and getting the things I need on the list and not coming home with the things I don't. So I have to keep myself very organized all the time. I take a medication, Aricept, to help with the cognitive issues, and so that's sort of the scope, along with the Parkinsonism that was discussed, that in addition to all of that I'm experiencing.
And Dr. Golby, just like to ask you a couple of comments on what Hadley has described. One thing that occurs to me, and Hadley, thank you for relaying in such detail everything that you are doing, is that what impresses me, well, many things impress me about Hadley, but among them is how on top of this you have to be. And Hadley, I assume you're seeing a movement disorder specialist. Is that right, in Missoula?
Missoula doesn't have, Montana doesn't have a movement disorder specialist, but I have a wonderful neurologist, and I do have specialists that I can travel to visit.
Yeah.
But for me, I find the travel quite a lot.
Yeah.
So I have a wonderful neurologist, but yes, it's important to have that on board.
I guess where I was going with that, Dr. Golby, is that there's such complexity here, and Hadley is obviously someone of great resolve and who has approached this with obviously not only great attitude but with great engagement. That's important, but there's a lot of complexity here, and she's doing a lot to contend with all of these things. So I guess I'd like your comment on the importance of that, number one, and if you would also touch on this cognitive question, because it's sort of the elephant in the room we tend not to talk about with all of these conditions, including Parkinson's. And there is a little bit of hope here, because Aricept, which is a drug that was initially used in Alzheimer's, as I understand it, has shown some promise in working and being helpful in some of these Parkinsonian conditions too. So would you comment on both the importance of engagement with a neurologist who knows what's what, and on the cognitive question?
Sure. The neurologist has to be willing not just to do neurology, but also to kind of play primary care practitioner with patients with MSA, because a lot of it is probably the biggest single thing is blood pressure control. As Hadley mentioned, this was a very serious issue in her until she got it under control with medication, and it might require very careful communication, where you have to make sure that the patient or family has a blood pressure machine at home, they know how to take their blood pressure properly, supine and standing, and that they report it in some efficient way to the doctor, and then the doctor gets back to them with some suggestion for adjusting the medication that raises the blood pressure, and there are multiple such medications available, and you can use them in various combinations. And there are all sorts of other non-medication techniques that can raise the blood pressure, and those can be used as well. And so even just the blood pressure alone is a huge project. And then there's all the other symptoms Hadley's mentioned: managing constipation, managing bladder emptying issues. So even temperature regulation can be a problem. It's another autonomic function. The breathing issue, no one has mentioned that so far, but in some people with MSA, they can have sleep apnea, and the sleep apnea might require a CPAP machine, might require a tracheotomy later in the course of the disease, and this is, again, the neurologist can facilitate interacting with a pulmonary specialist or a sleep medicine specialist. Then regarding the cognitive issues, as you stated, in MSA, it's not usually nearly as important as it is in the other Parkinson plus disorders. The anticholineesterases, which is the class of drug that donepezil belongs to, that's the generic name for Aricept, those are worth trying, but they don't help nearly as much as they do in Alzheimer's, and even in Alzheimer's they don't help that much, but still they're worth a try. And you have to keep in mind that those drugs can speed up the action of the GI tract and the urinary tract, and so they can aggravate incontinence.
Lots of questions coming in as well about Lewy body dementia, and so we want to get those engaged, and questions for Hadley as well that we will get to. So let's turn some attention now to Lewy body dementia, and we'll try to get in as many questions as we can in the remaining part of our conversation. But a first general question that I will pose to you, Dr. Pantelia, which is, people just want to know that how do you know you might have one of these conditions and not Parkinson's, when Parkinson's also has almost all of these symptoms, from blood pressure to urinary difficulties to constipation to walking problems. Does this go back to what you were saying before about what you called sort of the red flag of not responsive to levodopa and the speed of progression, the speed with which these symptoms advance? Are those the real red flags that tell you might not be dealing with Parkinson's?
That is absolutely correct. It's the speed as well as the severity. In Parkinson's disease, while when we're talking about advanced PD of duration greater than 10 to 15 years, you may certainly have very significant cognitive impairment, orthostatic hypotension, other autonomic difficulties, presumably due to the spread of the alpha-synuclein protein throughout the nervous system. This spread is much more rapid for reasons we're just really learning about now in Lewy body dementia and other atypical Parkinsonian disorders. So as Dr. Golby had been saying, it's not the type of protein specifically, but the extent, the geographic extent of involvement of the nervous system with a type of abnormal protein that dictates the symptoms. And so in Lewy body dementia, as the name suggests, dementia, which is functionally limiting cognitive impairment, sets in typically at the same time, if not even earlier, than any of the Parkinsonian symptoms that we've been talking about. And so that is a major red flag for Lewy body dementia in particular. In the case of MSA, as we've already been discussing, autonomic dysfunction, either difficulty with regulating blood pressure, particularly when sitting or standing up, or difficulty emptying the bladder with sometimes incontinence, sometimes the opposite problem of retention of urine. That could be an early red flag, as well as some of the others that are listed on the slide. I'm happy to talk about any of the specific symptoms, cognitive or otherwise, in more detail.
Peter wants to know, Dr. Golby, whether or not it's possible to have more than one of these symptoms at the same time. Dr. Pantelliat was mentioning earlier perhaps an overlap between CBS and the frontotemporal dementia, the question of apathy and sort of antisocial behavior, that those might be overlapping. Can you have more than one atypical Parkinsonism at the same time?
Well, you can, but generally when you have symptoms of more than one disease, it's not that you have two diseases, it's just that you have a case that is intermediate in its anatomical distribution. And each of these diseases is a spectrum. And the spectrums of the different diseases overlap at their edges. So the people who are in those overlap zones will appear to have two diseases. Now, having said that, you can go through the medical literature and find cases of proven occurrence of more than one neurodegenerative disease in the same person, but it's not clear to me that that happens any more than you'd expect by chance, given the prevalence of the diseases in the population.
One of the things we see on the slide here about Lewy body dementia that I know is something that happens a lot with this particular condition that we have not talked about yet, and perhaps you can comment on, Dr. Golby, is visual hallucinations. How prevalent is that, and is that something that can be successfully treated?
I can't give you a figure as to how prevalent it is, but I can tell you that in Lewy body dementia, there has to be, by definition, there has to be some kind of cognitive or behavioral abnormality that starts either at the same time as the motor problems or before the motor problems. And very often the first things to occur are visual hallucinations. Now, in Parkinson's disease, these happen as well, but only as a side effect of the dopamine-stimulating medication. In Lewy body dementia, the visual hallucinations happen on their own without medication, and then they can be aggravated by the medication. These hallucinations can be pretty frightening in Lewy body dementia, while in Parkinson's disease, they tend not to be frightening. They tend to be friendly, gentle animals or relatives who you love. It's a kind of a different thing than in Parkinson's.
The question about scans and what they can tell us about these atypical Parkinsonisms. Hadley, let me bring you back in for part of the answer, and then Dr. Golby or Dr. Pantelliat, you can pick it up from there. But you had a scan that helped differentiate part of what was going on. It was an MRI in particular. Can you describe what was learned from that, Hadley?
Well, it's subtle, but there was some showing of some atrophy in the cerebellum, and it was early, so that seemed like it was a possibility that could be part of the picture. And that was still, we're still trying to figure out the diagnosis. So that's what was on my scan. I know that there are MRIs that show a lot more significant signs than that, which someone else could probably describe.
So Dr. Golby, in these conditions, can scans tell you more than they can in Parkinson's?
Well, in Parkinson's, the MRI scan looks pretty much normal. You'd have to group together dozens of scans from people with Parkinson's and dozens from people without Parkinson's and average them together in order to see a difference. In PSP and MSA, there is a pronounced enough abnormality that you can identify it in individual patients. And as Hadley said, in MSA, the most important abnormality is atrophy, shrinkage of the cerebellum, and also the part of the brain that the cerebellum connects to, which is the pons. And there's also in MSA there's a pattern of scarring in the pons that forms this cross appearance. It's called the hot cross bun sign because it looks like the cross of frosting on a bun. In PSP, you don't have that. Instead, it's a different part of the brain stem just above the pons that atrophies. That's called the midbrain. And there are some other parts of the brain that atrophy in PSP, and also a different pattern of scarring.
Let's spend some time next on talking about what can be done. We've talked some about the shortcomings of what's available in terms of treatment, that levodopa is not terribly effective. Hadley has described with detail about the effectiveness with which he's been able to use both assisted devices such as a wheelchair and walking stick, exercise, both voice and physical therapy, and we have some other thoughts on that. But I'm interested in hearing more, Dr. Pantelliat and Dr. Golby, about what you've been able to recommend to patients in terms of effective therapies with dealing with these various symptoms that we've been describing. Are there things, Dr. Pantelliat, that you've been able to recommend to people that have been effective? Have you come up with, are there any new treatments on the horizon for dealing with any of these atypical Parkinsonisms? Is there anything out there in terms of new things in clinical trials that you think may be helpful in providing at least symptomatic relief, if not something that will provide something that would modify disease progression?
Well, David, a loaded question to be sure. We could easily spend the next hour talking about this, which I would emphasize is a very positive thing. The conversation today is different than the conversation we'd be having even 2 or 3 years ago because of what is on the horizon. That being said, the first point on the slide, I think it's crucial to emphasize that a movement disorder specialist should, if at all possible, be following these patients. And as Dr. Golby was saying, often that specialist needs to take on the role of a primary care provider in many ways. So, for instance, diagnosing on the basis of looking at the MRI and looking at the telltale signs that were mentioned for PSP and MSA. In my experience, unfortunately, even well-trained radiologists do not tend to comment upon that in their reports. So it's not adequate to have merely a report to look at, but the actual pictures of the brain on the MRI need to be brought in for the movement disorder specialist to review. Once the movement disorder specialist has a clinical suspicion about the diagnosis of one of these atypical Parkinsonian disorders, they can look at the scan and perhaps find those telltale signs. So beyond diagnosis, often the first point for all of these diseases is a trial of levodopa. So in the case of Lewy body dementia, just to fill in a little more there, a small trial of levodopa, as little as perhaps half a tablet at the standard dose of 25/100 milligrams, given 2 times or 3 times a day, can trigger visual hallucinations. So Dr. Golby was describing that is a telltale red flag that this is not run-of-the-mill Parkinson disease, and in fact we may be dealing with dementia Lewy bodies. So in that condition, there's a push-pull between improving the Parkinsonian symptoms, which can respond, at least to an extent, to the levodopa formulation, and worsening the cognitive symptoms, particularly those visual hallucinations, as well as sometimes confusion and agitation, which is a big part of dementia Lewy bodies. So a very careful titration and adjustment of medications is necessary. Often you find yourself in a very difficult situation of wanting to improve the Parkinsonian symptoms using something like levodopa, but at the same time trying to manage the visual hallucinations with the use of antipsychotic medication, which is generally something to be avoided if at all possible, but given that the hallucinations and agitation in dementia Lewy bodies can be so severe and significant, is sometimes simply unavoidable. For the cognitive impairment for all of these, as has already been mentioned, the cholinesterase inhibitors such as donepezil, and there are several others like rivastigmine in that class, can actually be quite helpful, particularly in dementia with Lewy bodies. The addition of memantine, the brand name would be Namenda, is also something that could help in addition to like cholinesterase inhibitors. So the combination of the two may sometimes be better than either of them alone. There's a little bit of data on that in the dementia with Lewy bodies. For the autonomic dysfunction, there, as has been mentioned, are a number of medications that are available, but I would always recommend starting with non-pharmacological interventions, such as using compression stockings, what's called an abdominal binder, which goes up to the navel and helps prevent the blood pressure drops, keeping the head of the bed up at night at about 30 to 45 degrees, increasing the amount of salt in one's diet. We can actually prescribe salt tablets, 1 gram at a time. Hydrating well throughout the day using sports drinks with electrolytes, such as sodium and potassium. These are some of the interventions for autonomic dysfunction, which, by the way, is very prevalent in dementia with Lewy bodies as well. It's under-recognized, but up to about 50% of patients with dementia with Lewy bodies can have severe orthostatic blood pressure drops, as has been mentioned in multiple system atrophy. There's certainly a lot more to talk about with regard to treatment, and I think Dr. Golby probably want to mention some additional things. But some of the exciting things in the horizon I would just emphasize are stem cell treatments for multiple system atrophy, which are under consideration, and there has been some encouraging data coming out on that. There's a trial being planned, and then antibodies that are meant to block the buildup of the tau protein we were talking about in progressive supranuclear palsy, especially. So these are in earlier stage clinical trials as well.
Well, I'm going to get to upcoming research in just one moment, but let me ask one current treatment question that's just come through that I'll ask you, Dr. Golby, which is a question about whether or not DBS, deep brain stimulation, can be effective in any of these atypical Parkinsonisms. So often one of the standards for whether or not DBS can be effective in Parkinson's is whether or not this person in the past has shown has had a good response to levodopa therapy. So my question, I guess, is if levodopa therapy is not very useful in atypical Parkinsonism, does that also mean that it's not very useful, that DBS is not very useful in atypical Parkinsonism?
I couldn't have said it better myself. That's right. Every center that does DBS gets a lot of referrals of patients who seem like they have Parkinson's but have never responded well to levodopa. And the referring doctor thinks, okay, let's try DBS. But it's not going to work. The patient has to have a really robust response to levodopa. And the problem is probably the same thing that I mentioned before about why levodopa doesn't work. The whole circuitry of the basal ganglia, which is the part of the brain that's most closely involved with coordinating and regulating movement, that area is much more diffusely degenerating in these Parkinson plus atypical conditions than it is in Parkinson's disease. And so the DBS just doesn't have the same physiology going on. It doesn't have the same pattern of electrical activity to correct that it has in Parkinson's disease. Now, having said that, there may be other areas of the brain that may be targets for DBS, at least in PSP. There are some experiments going on. There's a cluster of brain cells in the brain stem called the PPN, where there's experiments doing DBS in that area for the balance problem in PSP. It's not, and also in Parkinson's. It's not terribly successful yet, but at least it's an idea, and we shouldn't give up hope for DBS in the atypicals.
I would just second that. Yeah.
Yeah, thank you. Let's spend a last few moments on some of the research possibilities, and I'm not sure why, at least on my screen, the next slide is not coming up, but we'll try once more, see if we can get it to show. There we go. And what we hope we can achieve. you mentioned a moment ago, Dr. Pintelliat, that were some of the new exciting things that are going on in Parkinson's have to do with whether or not we can create ways of declumping those sticky clumps of protein that clump together, not only in Parkinson's but in Alzheimer's as well. We have sticky clumps that work in these atypical conditions, and there are various approaches. Give us briefly, if you can, please, Dr. Pintelliat, a sort of glimpse at what we hope may be in play for an approach that could work against those toxic protein clumps that would help us fight against these atypical conditions.
Sure. Well, as we're learning more about the way that these proteins fold inappropriately, if you imagine a piece of paper and just kind of crumple it together, these proteins we're talking about, such as tau, alpha-synuclein, amyloid beta, they seem to have in common certain ways that they clump together and are able to damage the ability of cells in the nervous system to function, brain cells to function. And one of the ways that we've been looking at trying to improve these conditions is by preventing this aggregation or clumping of proteins. So one way of doing that is by using an approach called the antibodies, antibody-based approach. These are synthesized in the lab, typically injected intravenously, and the clinical trials that have been beginning over the last few years are looking at whether patients' symptoms can be improved, or at least the progression of disease, like PSP, can be slowed as a result of the use of these antibodies. And this is really tremendously exciting because it's believed that if this approach proves to be successful in one of these diseases, such as a pure tauopathy like PSP, it may perhaps be applicable to other conditions that may share this pathobiology, like Alzheimer's disease, for instance.
And one of the really exciting things is that potentially good news for Alzheimer's may be good news for PSP, and vice versa, that good news across all of these neurodegenerative diseases may benefit one and the other. We have to wrap up in just a few minutes. Dr. Golby, I know you have a patient awaiting you in just a few minutes, but we have a genetics question I want to get to you before you have to leave us, because you did some of the land.
I found a slot to reschedule him. Go ahead.
Okay. Well, you did some of the early landmark work in genetics, so I want to get this question to you in genetics in Parkinson's disease. A number of people want to know about the hereditary factor in this. One person wrote in that his father had MSA, and he now has Parkinson's, and wonders if there is a genetic connection. What do we know about that? We know that there are genetic mutations now, and you've played a role in that early research, genetic mutations in Parkinson's. Do we know about a genetic interplay between MSA and Parkinson's or these other atypical conditions?
There's a slight genetic overlap. This protein that aggregates in both MSA and in Parkinson's, called alpha-synuclein, there can be subtle variations in the gene that codes for alpha-synuclein that affect something about the manufacture of the protein, maybe the amount of the protein or the shape. And there is such a variant that is present in MSA, and there is another such variant that is present in Parkinson's, but these each contribute just a tiny amount to the overall population risk of having the disease. So if a person with MSA has a relative with Parkinson's, I'd say the most likely explanation is just coincidence, because Parkinson's will occur in 1.5% of the population at some point in their life. So that's a large number of people. So that means that of all the relatives that a person with MSA might have, 1.5% of them will develop Parkinson's.
And before we wrap up and might get a last word from Hadley as well, we do want to really encourage people to participate in all forms of research. We've recently increased the bandwidth of the Fox Trial Finder project within the Michael J. Fox Foundation to encourage people to participate not only in all forms of Parkinson's research, but also to participate in atypical Parkinsonism research. And a number of questions still, and I'll ask Dr. Pantelya to answer this before we get a last word from Hadley. Just on diagnosis, Dr. Pantelya, people wondering about the DAT scan, which is a new kind of scan that can be helpful sometimes in confirming a Parkinson's diagnosis. People really wondering if that's something that can also distinguish perhaps some of these atypicals. I think people really want to know if there's a definitive way of distinguishing these atypicals, or whether or not it just comes back to what you were saying before about non-response to levodopa and the quick progression.
Well, so in the case of the dopamine transporter scan, or DAT scan, while it could confirm the presence of one of these progressive degenerative Parkinsonisms or Parkinsonian disorders, it does not reliably distinguish on a single patient level between Parkinson's disease and one of the atypical Parkinsonisms that we've been talking about. So unfortunately, that really has very limited usefulness. We've already talked about the use of structural MRI, and really some of the best research has been done, and there are ways of clinically being able to look at some of these areas that Dr. Golby and I have been talking about in the brainstem and the cerebellum, and in a quantitative way distinguish between Parkinson's disease and one of the atypical Parkinsonian disorders. That being said, there's still quite a lot of work that needs to be done in this to discover a reliable biomarker in living people and living patients to distinguish between them. I think that there are a number of them on the horizon, blood tests looking at the cerebrospinal fluid, but they're not quite ready for prime time as of yet. There are some ancillary tests in the case of MSA. There's something called a cardiac MIBG scan, which we don't have time to talk about, that can really help confirm the diagnosis of multiple system atrophy. But as of today, all of these disorders are definitively diagnosed by looking at somebody's brain under a microscope.
Dr. Pantelya, thank you. Hadley, I want to return to you before we conclude and just ask you, if you would please, to kind of bring our conversation to a close. These conditions are so challenging. I think you exemplify in so many ways what it takes to contend with them by the way in which you've approached this with such courage and determination, by the way you have tackled this with, I think, such courage and such will, and you inspire many of us, I think, with your story. And so I would just like to conclude by having you say a few words about the work that you're continuing to do for the Parkinson's community, and to thank you so much for your participation in our webinar today.
Well, thank you so much. I'd like to share sort of some closing thoughts about things that have keep me going, and staying involved, as you said, is really important for me. I do have a group in Missoula that I co-founded called Summit for Parkinson's, and it connects others in the community with resources for Parkinson's. But for me, staying involved in my MSA community and still with my Parkinson's family that I first met is really important. I have some dear friends all across the globe that I am very thankful for. And just to keep enjoying what you love. Things change, and they change for me every day, but I adapt, and I may not do the same things that I used to do, but I just do them in a different way. And I plan on waking up every day and making the most of it. A support system is just really, really important. My family has been a wonderful support system for me. It's very important to me. And most of all, to keep moving. So many resources out there if it's PT or some sort of therapy, keeping moving is really important, and staying involved and informed. The Fox Trial Finder is a really great. I'm so happy that they have the atypical Parkinsonisms as part of that now, and there are things within each person's community that they can get involved in, hopefully, and keep active with. So I really thank you for having me as part of this webinar, and I thank everybody out there listening, and for this family. We all have to stay connected and support one another.
Hadley, thank you. Thanks so much for being part of this today. Thanks to Dr. Lawrence Golby and Dr. Alex Pantelliat for being part of our webinar today. We'll be sending a link to the webinar on demand so that you'll be able to listen again or share with others. There'll also be a survey link in that email so that you can share with us your thoughts on today's presentation. We also would like you to mark your calendars for our next Third Thursday webinar, which will be on September 15th, when we'll be talking about the use of medication. How do you go about choosing medication? How do doctors choose what to prescribe? And how do you go about updating your medication regimen? That's going to be our topic on our next Third Thursday webinar on September 15th. Until then, I'm Dave Iverson. Thanks for joining us.